Hi, Dr. Dave Webster again in my video blog. This is my second video on the basics of PET-CT scanning, helping you hopefully to understand why the rest of the world has considered Ontario's lack of access to PET a travesty. So I'm going to show you why PET-CT became the cornerstone of imaging management of patients in the era of personalized medicine. This is a very exciting era where basically initial workup of patients and treatment is based on the response of the patient's own tissues to treatments and so on, but sadly not available if you're in Ontario. So, positron emission tomography or PET scanning, the key point about this is that PET images function where the action is. So this is a scale kind of a diagram here. You would see a person standing up here in the 1 to 10 meter range kind of thing, pretty tall guy at 10 meters, I guess, but the cellular action is down here where this is what's happening in your cancers, for example, and that's where we're going to be aiming our therapies. So we've seen how a CT gives us staggeringly good anatomy or structure in the 1 to 2 millimeter range, about the size of a frog's egg. But unfortunately, this is orders of magnitude above where the actual action is occurring within the cells, and of course, zero insight into the physiology or function of the mass, of whatever cells happen to be in a mass it identifies. On the other hand, we see the PET scan doesn't have great resolution. It's 5 to 6 millimeters. Newer cameras may be slightly better, but that's not really what's the power of PET. It's because we have the sensitivity to be able to image the physiology where the action is taking place in the cells themselves. So PET scanning is the most advanced form of functional metabolic imaging we have. This is an unfortunate patient with stage 4 very advanced multiple myeloma. This is the patient's brain and their bladder, but the rest of what you see here are very active cancer cells eating all that sugar, this again being an FDG PET scan. However, believe it or not, still to this day in Ontario, the standard of investigation is a skeletal survey, as we talked about in my first video. I mean, the Smithsonian Institute is still looking for primitive medical cultures that would still be using this kind of investigation to investigate, patients with this disease. But this is evidence-based medicine in Ontario, and this is how the rest of the world offering PET would consider the standard of investigation for these patients. So back to that diagram I showed you before in nuclear medicine. Remember, we have this radioactive beacon. Turns out it's going to be fluorine-18, which is technically a positron, but we inject that in the patient. It's from this that we create the images from the energy coming into the patient. The power, remember, came in the chemical and molecules, which traces some pathogen physiology. Now, we have many more molecules we can use in PET scanning as opposed to general nuclear medicine, and we call these positron-emitting radiopharmaceuticals, or PERS, for short, and there's, 100, 125 different kinds of molecules currently available, with really an enormous number theoretically positive. But as I've said, the most common molecule we're going to use is called deoxyglucose, which means we've removed one oxygen, but as far as the body's concerned, it still is glucose, fortunately, and so it takes it up as it would sugar, and so we call FDG or fluorodeoxyglucose. So the reason FDG PET is so useful is because all mammalian cells can use glucose for fuels, but it turns out that cancer cells can only use glucose, and they do so very inefficiently. And so, as we've seen in our pictures here, the cancer cells stand out against background tissues. This is the liver. You can see it here, but you can see how that's a normal tissue eating glucose, and this is the cancer cells eating glucose. Again, this is actually the bladder and activity being excreted in the kidney, so this here isn't cancer. Now, there are many roles for PET in oncology, and currently there are maybe 12 to 14 different kinds of cancers where we can use PET successfully, keeping in mind, however, that we're looking at a bunch of possibilities here, but for each type of cancer, not necessarily all of these apply. And again, it goes back to what I said in my first video. You must use the most appropriate imaging device for whatever you happen to be looking for. So we don't really use PET so much for diagnosis because, remember, it is just really sugar. However, what we will see in dramatic cases, how it can direct the person doing the biopsy on the abnormal mass to where the most likely chances of finding the active cancer cells are. We use it in staging, responding to treatment's a huge role, restaging recurrent tumor, and what we'll see, sadly not in Ontario, but when patients have radiation therapy, we can actually reduce the dose of the radiation the patient needs by as much as 60% because we can direct the beam just to areas of active tumor, and in fact even more, as you will see. There's lots of research and uses, and this does hold the future for how personalized medicine will be. Now, the best way to understand the impact is the case example of why PET is the world standard imaging management for cancer patients, among other things, as we'll see. But it will demonstrate, I believe, the profound impact PET can have on patients' lives, their treatment options, and their futures. But most importantly, it demonstrates the travesty in Ontario of not having access to PET-CT scans on a routine basis. So this is a 62-year-old male. He had colon cancer, and his conventional forced workup by Cancer Care Ontario was a CT. He also had an MR because he had a couple of masses in his liver, and they determined confidently that these were benign growths in his liver, happened to be called hemangiomas, is what they said. However, a repeat CT, of course, a standard follow-up, and now 7 months later after his surgery, now determines that the masses are cancer metastasis to the liver, and the CT can only make even that assessment or idea because the masses were getting larger in sizes. This would not be expected with the hemangiomas. Now, a PET-CT, of course, would have shown this at his initial workup. Instead, he lost 7 precious months before he finally got to the proper therapy for his liver cancer. Now, so he undergoes his therapy, and then, of course, because he's in Ontario, he has to be followed up by a CT. So here's his post-treatment CT of his liver. You may remember this from the original talk I gave, or talk number 1, but liver here, and these were the abnormal masses on his CT in the follow-up scan. Okay, so the obvious question is this, scar tissue or active disease, the obvious question for the patient. What the radiologist said to me was, Dave, the man is toast. But what he had in the report was a little more diplomatic. There is progression of the cancer in his liver. In other words, he has terminal cancer. So the man, of course, is devastated. He was about to travel to Florida with his wife, and he decides he better sell his major business, doesn't want his wife burdened with that. But because of my activism in PET, he actually pays for his PET scan. So here's that CT scan again, and there's the masses, right? Here is his PET scan, and guess what? These areas here that the radiologist had called cancer are, in fact, as you can see, cold, as I would say. There's no uptake here. So here again, we have a CT showing a mass. And remember, a CT has zero ability to determine whether this is what the physiology or what's going on there. But the PET shows a cold area. This clearly is scar and not cancer. But in addition, it shows this little new 1.5 centimeter finding, which is a new metastasis to his liver, and this was actually missed on the CT. Not that it would have made any difference because they'd said he was terminal anyway. However, his surgeon sees all this and he says, look, go off to Florida, have a great time. When you come back, we'll deal with this. Oh, and by the way, you don't need to sell your business. So, Ontario's standard of care is CT follow-up, and also, of course, the initial follow-up. But based on his CT, he was told to get his affairs in order. Based on the world standard of PET, he got his life back. So in Ontario, what is the current standard of care for colon cancer patients? Well, serial CTs, both for your initial workup and your follow-ups, remember. But what's most important to understand is that although some people will eventually qualify for a PET scan, up to 50% of patients who have recurrence or spread of cancer from their colon or their original colon cancers, they are not allowed routine access to a PET-CT, which would be considered standard of therapy by doctors even in Paraguay. So, consequences for this particular patient who has the misfortune of living in Ontario, of course, according to to Ms. Wynn, patients first in an evidence-based system. But his workup, initially, his CT and MR misdiagnoses his liver masses as benign masses. He loses the 7 precious months, and then finally the CT decides that he's actually cancer. Sorry about that. And then his post-treatment cancer CT scan shows that he now has terminal cancer. So now without the PET scan, he would have only been offered palliative therapy. So, and of course, sold his thriving business. Now, so you can decide for yourself, is this patient's first health care in Ontario as proposed by Premier Kathleen Wynne and our Minister of Health, Dr. Eric Hoskins, or not? What I can tell you, and I will show in videos, that Ms. Wynne and Dr. Hoskins are actually very proud of what Cancer Care Ontario has done to our patients to block them from PET scans. So as I've said before, you need to follow me on the website and so on, and it isn't enough just to do that, be horrified by my videos. What I'm hoping people will do is use the power of social media to get the facts out to the public. Because as you might have guessed, the mainstream media will not touch this and haven't for 15 years. But then we also, of course, need to demand the politicians in Cancer Care Ontario in particular defend their actions. But one more thing I'd ask you to do. On my website, there's a petition. In 2005, the Canadian Association of Nuclear Medicine declared the Liberal government's pet experiments on patients were unethical. Let me repeat that. They declared these experiments way back in 2005. It's now 2017. Were unethical. They continue to do these experiments, I can assure you, at McMaster University, in fact. So they also passed the following unprecedented motion. That is, the panel that they wanted a panel of Canadian experts in ethics and health policy. Note, they didn't say science, just there was no science. Everybody understands that. Nobody at Cancer Care Ontario is trying to pretend there is any science. But they wanted the ethics and health policy reviewed so that they could understand how this possibly could have happened in a place like Ontario and not some banana republic. So it is time to demand that Kathleen Wynne finally carry out this motion and defend what she is so proud of. Thanks for watching, and there'll be lots more videos, and please do what you can to try and help our cancer patients. Thanks.